Alaikum. Hi all. I just want to thank those who are still present. Last day, last session.
Yeah, last day, last session.
The end of the
They are
week.
sacrificing their life. That's why we
We
finished
are
the work and
technically
coming to the
done.
city. Yeah.
Before the last session, Doctora, if you allow me, there is one more session. There is a guest of honors after this one for half an hour. So we want you to announce that they can join us in Hall A. Thank you.
Yes, you can join Dr. Amri in the Hall A after.
Yeah,
Okay.
10 o'clock. Thank you.
So let's be the dessert, okay?
Okay, thank you.
I am honored really to moderate this session among all those eminent friends and dear and eminent speakers and dear friends. We will try to once again define this dry eye disease. This is what I call personally a سهل الممتنع, because we all face it daily in our practice. We try somehow to deal with this pathology, and it works sometimes, fortunately, and sometimes it doesn't. So let's make it just like a brainstorming today around this table to share our experiences. Maybe it can make things easier for us and for our patients. So we'll start with the overview of غني عن التعريف الدكتور صفوان بياتي. خذ راحتك ولا حسكتك ولا انت بقى انطلق.
It's my great pleasure to meet you here and as a moderator for
12 minutes.
عمري هنا.
ايوه يعني
12 minutes please, not more.
I have the sensitivity with Dr. Muhammad, and here I will present two presentation together. So it's 12 by 12, 24, and
Sorry, it's only 18 minutes maximum. Thank you.
Most welcome. So Dr. Muhammad was very generous today with us. So I think that I can keep continue. And as an importance for this subject, I changed to overview of OSD. I think that when we are talking about OSD, it will be wide, and we can summarize a few important points in classification, in overview through the diagnosis and management. Now I will go through a main definition as an ocular surface disease. I just have a problem with these, that I need to minimize them, and then in a way that I can see my words. So OSD indicate the damage to the surface layer of the eye, namely mainly cornea and conjunctiva. There are many causes of ocular surface disease, but what we need to concentrate here, two most common cause, a dry eye syndrome and blepharitis. And causes in general, we have a blepharitis, dry eye syndrome, eye allergy, decreased tear quality or production with age, chemical or thermal burns, side effect of medical treatment or prescriptions, medications, keratitis, Sjogren disease, and again, I have meibomian gland, MGD. If we will go to the inflammatory vicious circle, I think that my colleague, Dr. Osama, my brother, he will show you the details and the influence of the inflammation in as a key role for the OSD. So I will leave this subject to my colleague, Dr. Osama. The symptoms of OSD, the most common symptoms of dry eye syndrome, and are a dry, gritty, sandy sensation in the eyes, redness, mucus discharge, fluctuation of vision, contact lens intolerance. Many of these symptoms can also be caused by other ocular conditions such as blepharitis, inflammation of the eyelid, and ocular allergy. Dry eye syndrome are often made worse by activities where patients tend to not to blink frequently, such as reading, working on a computer, and watching television. Dry eye syndromes symptoms are also generally worse toward the end of the day. And that's the mainly issues when I'm asking the patient, this symptoms you have it early morning or end of the day, because it differ with the causes. Blepharitis symptoms are very similar to the dry eye symptoms. Blepharitis tend to cause more redness and the crusting of the eyelids, and the symptoms are often worse in the morning, as I said. So questioning the patients when the worsening of the symptoms, an important issue to have from the history as a main cause of this symptoms, from where is a MGD or a dry eye syndrome or dry eye disease, and improve throughout the day. That's in blepharitis. Now, if we will go to the causes, dry eye syndrome is primarily caused by poor quality and quantity and stability of the tears. Blepharitis, main inflammation of the eyelid. Blepharitis is often divided, as we know, anterior, involving the front aspect of the eyelid, including the lashes, and posterior, involving the eyelid margin, including the meibomian gland. In reality, many eyes have both forms of the same at the same time. Risk factor for dry eye syndrome: advanced age, female, dry environment, smoking exposure, connective tissue disorders, Sjogren's syndrome, rheumatoid arthritis, conjunctival scarring from prior injury, chemical or mechanical injury wide, certain medication, antihistamine, beta blocker, vitamin A deficiency, prior eye surgery, especially corneal refractive surgery, and more especially and more precisely the LASIK, because we are cutting the nerve in the anterior third of the cornea where their passage, and even in the trans-PRK, we are damaging the end of the nerves were responsible for sensation of or giving the afferent reflex of the afferent innervation for the dry spot. So damaging these nerves 100%, we will end up with a dry eye for a while of time until the regeneration of these nerves. While in SMILE, we are not facing that because we are extracting the lenticule under the level of these nerves. So refractive surgery, now we need to specify it, which one, and LASIK and LASIK is the first, and then PRK second, and SMILE is the least. Now, the risk factors of the blepharitis, the development of the dysfunction MGD can occur as either low delivery or high delivery of meibomian gland lipid onto the ocular surface. High delivery, also termed hypersecretory MGD, result in a large volume of MG lipid accumulating at the lid margin, forming a foam-like tear. Hypersecretory MGD is usually secondary to systemic conditions such as seborrheic dermatitis, atopic dermatitis, and acne rosacea. Low delivery stage of MG secretion can be further classified into hyposecretion or MG obstructions. So hyposecretion develops when MG atrophy occurs, resulting in a generalized reduction in the number of function MGs. MG obstructions is the most common form of MGD that we have it now. With obstructive MG, hyperkeratinization of the epithelium lining the MG duct occurs. The exact causes for the development of hyperkeratinization is unknown, but inflammatory mediators are suspected. And now, with the research of Professor Rohit, they found that a lot of mediators in not only MMP9 and controlling of these inflammatory, as Dr. Osama will mention in his presentation, will improve the function of the MG. Now, complication, definitely all these symptoms that will, if it will keep continuing and it start to be chronic, it will lead to corneal dry spots, corneal abrasion, corneal infection, corneal scarring, corneal thinning, corneal perforation. Now, what's the test that we can do it frequently in our clinic to identify and find out the problems, whether it's MGD or it's a dry eye disease syndrome? Most dry eye test methods, such as, and I will start with the simplest one that we are all have it in our clinic, is the breakup time, Schirmer test, corneal staining using simply fluorescein test. And I think that fluorescein is available in all our clinic. Now, when we are going to the tear osmolarity, 100%, not all of us having the machines, but it start to be a small, tiny. That's so it start to be or we can have it, and it start to be near to be. We can take it, all of us, because it's important to assess the osmolarity of the tear, as we know that the osmolarity will increase with the reduction of a production or increase in evaporation or instability. And this osmolarity, when it exceeds 316 milliosmol, then apoptosis and toxicity to the main cells, the goblet cells, then we will have more instability and more damage to the other cells in the conjunctiva and in the lid margin, the meibomian gland. Diagnostic imaging methods such as interferometry and meibomiography now started to be there and installed in most of the tomography. So most of the tomography that we have, they have the meibomiography. So we can use it to analyze the numbers of the functioning meibomian gland. And that image provide valuable information to help characterize patients as evaporative or aqueous deficiency, but cannot predict which patient have clinically significant ocular surface disease. But osmolarity, for sure, when it's above 316 milliosmol, it indicates that there is an indicator of inflammation and directly correlate to the level of the inflammation, especially if we assess it with the MMP9. Now, with this osmolarity, if it's increased, definitely correlate with the moderate to severe dry eye. Now, if we will go to an inflammatory mediator or markers, patient with the dry eye disease display an array of inflammatory markers such as IL-1, IL-6, and IL-8, interferon gamma, and tumor necrosis factor, alpha, MMP9. The most available factor or marker that we can detect it is MMP9, but unfortunately, MMP9 is a non-specific marker that it can help us saying that there is an inflammation, but which kind of inflammation, in which part of the conjunctiva or in the lid margin, it's not specific, but it can also guide us to the improvement, because reduction of the MMP9, it means that the inflammatory condition, it improved. Measuring inflammatory marker in the tear help assess the level of inflammation. MMP9 is an ideal biomarker for inflammation, since it's elevation in MMP9 was shown to place the development of the corneal staining, but still it's not specifically related to the dry eye disease. And as shown, that this is the way how to see the marker, and this is the tools, the simple tools, and it's one used, and we can use it for one patient and throw it. So it can be available. The MMP9, an inflammatory marker produced by stressed epithelial cells that is consistently elevated in the tear of patients with a dry eye disease. Rapid in-office tests that detect MMP9 in tear, but does not quantify inflammation yet. Now, if we will go to the management, I will base my management now here on MGD and the simply I will summarize the going to the dry eye. The MGD workshop recommended a severity-based approach for the treatment. It's important to first properly grade the level of MGD severity based on signs, symptoms, and the grade of MG secretion, and they are staging it from 1 to 4. So from 0, all gland patent, clear fluid is expressed, 1 or 2 gland partially obstructed. That's in grade 1. So if it start 1 or 2 gland partially obstructed, we are starting grade 1. And in grade 1, clear to cloudy fluid is expelled on a mild digital pressure. If we will go to grade 2, 3 or more partial obstructed glands, cloudy or opaque fluid is expelled on digital pressure. If we will go to grade 3, 1 or 2 blocked glands with many partially obstructed glands, tear film foaming, as I said, is noted along the lid margin. So when we will reach to a foam tear film, this is a grade 3. Inspication notes toothpaste-like expression with a toothpaste. It's just like a worm with a moderate to hard digital pressure. If we will go to stage 4, 3 or more blocked gland with the remaining gland partially obstructed, meibomian, meibom difficult to express, even with the hard digital pressure. Now, if we will go to
left, please.
Sorry,
2 minutes left.
Yeah, because it's two a presentation, Dr. Safa. It's not one presentation.
Yes.
I will have 2 presentation here. It's the first overview and then the diagnosis of the dry eye. So I'm putting it in 2. Anyway, I'm in a final issue, so don't worry. We will have a lot of time.
Thank you.
Because my name is in 2 presentations. Stage 1, lid warming and expression, and that warm compress, which include increasing the temperature of the lid with the compress to allow the altered meibom to be melted by heat and released by compression from the MG. This can be done manually in this stage. In stage 2, we need, addition to stage 1 treatment, we need hygiene, commonly referred to as lid scrubs. In stage 3, all what's mentioned in the first 2 stage and the first stage, and adding to it the use of omega-3. Well, there is a lot of controversy here around the use of omega-3. So that's why I will all mention, because there's a big study shows that there is no any difference between the use of omega-3 and non-use of omega-3. But personally, I will use omega-3. There is no any harmful from it, and I'm feeling that my patient more comfortable on it. Now, we are still in stage 2, the use of artificial tear here. We need to use artificial tear that compatible with this stage, and it should contain the oil emulsion tear, not the tear that contain only hyaluronic acid. Because if we will use in the MGD hyaluronic acid only, then we will end up with the same evaporation and we will not improve the condition. Topically, or the topical and oral antibiotic here, in the past we were used only doxycycline, but now topical azithromycin 1% of phthalmic solution is broad spectrum macrolides topical antibiotic with presumed anti-inflammatory property, also showed a significant improvement in both clinical sign and symptoms of MGD, twice daily for 2 days, and then once a day for 14 to 30 days. The study examined the use of oral azithromycin 500 milligram per day for 3 days per week over a period of 3 weeks, was performed with a follow-up of 1 month. Statistically significant improvement were noted in breakup time. Sorry, just I need to remove that side from my site.
We need to conclude, Dr.
Doctor, I have another presentation in the same. So this is a 2 presentation. It's not 10 minutes. It's 20 minutes.
Yeah, the boat should take 20. We are at 19 minutes now.
So means that
you have still 1 minute to finish the both.
The 20 minute both.
But yes, time is ticking away, Ustaz Al-Aziz. So
okay. So I will skip to stage 3 and 4. All treatment that's mentioned above with the use here. We need to use the topical anti-inflammatory medication. Should also be considered Xiidra, Liftigrast, and cyclosporine. Now I will skip the new technology because I don't think so that we have. But I will say something to the tear when we are treating the dry eye that have breakup time that affected in with MGD. We cannot use only the hyaluronic acid. We need to use all the component of the tear. So the tear should contain, the artificial tear should contain hyaluronic acid, carbomere or methylcellulose, glycerol, and the other kind of lipid that can protect. So there is one application in the Apple. I think that also it's in Android. It's called Eye Protector, and this application reminds the patient to blink. And this is a very important and very it's a free application and can be used by. I'm advising all my patients to use this application to remind them to blink. And great thanks for all.
Thank you very much, Dr. Safwan Bayati. It was really a great overview and a great overview of the mean of treatment also, a mean of diagnosis. Well, we understood now that we cannot claim to overcome with dry eye without breaking the inflammation. And that will be the topic of our friend, Dr. Usama Jlaidi. The stage is yours. Come on.
Thank you very much. Thank you, Dr. Safwan, for the nice talk. Is the first slide there?
Yeah.
So basically, I'm going to talk about the role of inflammation in dry eye disease. From definition from 2007, Deuce and 2017, part of the definition of dry eye is ocular surface inflammation. So technically, you shouldn't have a dry eye in the definition without some sort of ocular inflammation. So inflammation is very important and very important role in the etiology of the dry eye and very important to treat it. There's as Dr. Safwan said, there's a vicious cycle of the dry eye, ocular film instability, cause hyperosmolarity, apoptosis, that will kill some cell, creating inflammation, release of cytokines, one of them will be benign, it will cause goblet cell damage, and that's also creating more tear film instability, and that's cause vicious cycle. Same thing with the lid meibomian gland. There's a flora, bacteria, release toxins, cause lid inflammation, meibomian gland orifice inflammation, some of them obstructed, inflammation of the meibomian gland cause instability, and that's another vicious cycle. And that vicious cycle can be presented from different causes. One of the commonest one, MGD, but there's too many factors can cause the vicious cycle to go to these dry eye circles. And one of them is really the autoimmune disease, inflammatory. We know that's inflammation. But all other factors it can cause dry eye and play part in inflammation role. Basically, there's two efferent and efferent pathway for inflammation. So any stress in ocular surface, conjunctiva, releasing inflammatory, that taken by antigen-presenting cell, go to the lymphocytes, which the lymphocytes producing interleukin, toxic neutrofiltrating factors, and that's migrated by T lymphocytes to the ocular surface and cause inflammation. And in the dry disease itself, there's a lot of arrays of inflammatory markers, and one of them is cytokine, chemotaxis, interleukin 1, 6, 8, gamma interferon, tissue necrotizing factor, and MMP9. So a lot of markers increase it with the dry disease. When we have a patient with dry eye, usually we don't see a classic sign of inflammation like what we see in other parts of the body. So we don't see much redness or swelling or pain, because the inflammation is at a lower level. Sign when examine the patient with the dry eye, always we're looking for traditional way, tear breakup time, Sherman test, tissue osmolarity, and imaging like mammography. All this will help us to diagnose dry eye, help us to differentiate, is it evaporative, is it aqueous deficiency, but doesn't detect it, is it clinical significant ocular surface inflammation or not? Although, as you know, most of our patients have evaporative and the aqueous deficiency mixed together, almost 75% of our dry patients have both, but we cannot assess the significance of inflammation. But usually the presence of corneal staining and conjunctival staining, that's a very good indicator. There's a level of inflammation which is clinically significant, and they have very good correlation with raised MMP9. The other one is tear osmolarity. Higher tear osmolarity, more than 316, is usually rated moderate to severe dry. Inflammatory marker is, if we measure the inflammation, one of the commonest one we're using in our lab, MMP9, because it's very easy to do and really correlated well with the corneal staining. It's produced by any inflammatory stress epithelium cell, but it's very simple, it can be done in our clinic, its office. But the problem with this, it's either positive or negative. So it doesn't quantitative how much the inflammation, and also doesn't cause the cause of the inflammation. But it's really very easy to do, and it detected there's inflammation and very have strong correlation with the dry eye survey score, fluorescein stain, and tear breakup time. So it's a very common tool. We could use it in our clinic to help us to assess, is it a clinical significant inflammation, because that can help us in the management. Any patient who had inflammation in dry eye, there's different modality now we're using to control the inflammation than other than the artificial tear supplement. Corticosteroids, cyclosporine, topical tacrolimus, laphitagraph, tetracycline, and doxycycline, azithromycin. As we know, corticosteroid it works against all type of inflammation cascade. It's very potent anti-inflammatory. It's very effective. It have very fast effect, but you have to use it for a very short time, because a week, 2 weeks or 3 weeks, that's what I usually use. I usually use FML or Lotamax to reduce the risk side effects such as cataract and glaucoma. Very important to explain to the patient, steroid will help, but you need to use it with shorter period just to reduce the inflammation at initial stage. And then we have to use another things to control the inflammation. One of them is cyclosporine. Cyclosporine, as we know, we're using for a long time, more than 20 years now, is anti-inflammatory, immune modulator effect, and had anti-apoptotic. It worked by inhibiting T-cell mediated inflammation, by inhibited interleukin 2 activity of lymphocyte. It's well-known cyclosporine known to increase expression of transforming growth factor, and usually topical use reduces the number of activated lymphocytes in the conjunctiva. So by the cyclosporine, basically what to do is to block activation of lymphocytes. That's why the effect of cyclosporine take a long time, because any active T lymphocyte still will cause inflammation, but will stop activated lymphocytes. So expected to the work start like 2 weeks. Usually the effect started a month to 3 months to have effect. So if you give cyclosporine, always explain to the patient we need to use for 3 months before considering its effectiveness. Is the concentration of cyclosporine we're using Restasis, which is Allergan 0.05. It's approved by FDA, and it works, as we say, until T lymphocyte activation and stop the production of certain cytokines. Topical tacrolimus is another have the same mechanism, cyclosporine, but it's really much stronger, almost 10 times more stronger. But the problem with tacrolimus, it tends to cause more irritation ocular surface. The other one available is Lafitagraft, which we had it in Emirat now for 2 years. It's FDA approval also. It's the mechanism of action slightly different than cyclosporine. It's working the binding between LFA and ICAM. So block interaction of the ICAM on the tissue level, vascular level, and endothelium cell level. So it's at different level. It reduces the migration of inflammatory cell, which is already active to the tissue, so prevent inflammation, as well as prevent activation of the T cells by prevented antigen interaction. So Zidra show in the study sets it reduces overall inflammation response, and it works in both active and active. So by that means any active T cells, it can block it, and that's have make it has faster effect. Like 2 weeks, you should expect some effect with Zidra.
2 minutes, Dr. Osama, 2 minutes left.
Tetracycline, doxycycline is another modality, is antibiotic, anti-inflammatory as effect, and it's azithromycin now using more common because both have same effect, and you can use it like for shorter duration because stay longer. It can be given in pregnancy. Usually we give it 500 for 3 days, or you can have longer, or you could use topical. So all anti-inflammatory can overacting each other, steroid, cyclosporine, tacrolimus, and Lafitagraft. In the management of dry eye, from stage 2, we use anti-inflammatory, dose, and also Cedar is also recommended anti-inflammatory in the treatment of patient with the dry eye. When should we using cyclosporine Lafitagraft? Anyone with stage 2 and above, we're using it. Any patient who use artificial tear more than 4 times, I always consider using it. In moderate conjunctival and corneal stain, if someone had very high osmolarity, more than 316. If you did benign and positive, really this patient need to consider some anti-inflammatory. And in the patient with moderate meibomian glands function, which is not controlled by simple lid hygiene. Conclusion, inflammation play an important role in dry disease. It's important to treat the inflammation dry disease to stop the vicious cycle. So, and prevent worsening of the disease. Because if you start leave the anti-inflammatory treatment for later stage, any damage at the goblet cell or meibomian gland, all damage may not come back. So it's very important to start it early before permanent damage. Steroid is very important anti-inflammatory. It's useful to use it for short period, but cannot be used for a long time. Cyclosporine, Zidra drops is very safe, effective anti-inflammatory to treat dry disease. And remember that different anti-inflammatory mediating can work different mechanism and could be combined together if it's possible. And thank you very much. I still have 1 minute.
Yes, thank you very much, Dr. Osama. It was great. It was very interesting inputs, and you could put it in the right time. So thank you. It was great. Now we'll move on to the management of the dry eye, and we'll try to benefit from the great experience of Dr. Samer Hamada, who is, I think, with us. So, Dr. Samer Hamada.
Mic is closed, Samer. Hello.
Yes, he's speaking to
Samer, okay. Samer, he's listening to us?
Yeah, he is listening, but he is speaking to somebody.
Okay, maybe he's listening, talking the phone.
We lost the 2 minutes we won with you.
Samer, maybe he's not. He mutes the. Yeah.
Dr. Samer, Dr. Samer, do you hear me? You can. Dr. Samer, it's yours. He muted the computer. Dr. Samer, he sees us.
I finished early than expected. That's why.
Yeah, that's it. It wasn't. It wasn't supposed to be so.
You have
So
to. You have
maybe,
to
maybe I can do my presentation. Can I start with we switch?
I think you start use and then you communicate with him maybe.
Yeah, he will. I will start maybe my presentation. Okay.
Okay.
Let's go. Let me share my screen. Desktop. Use this.
Hi, good afternoon. Can you hear me now?
Yes.
Yeah, we are hearing
Good. Okay. Sorry about that. Can I share my presentation with you now?
Yes, of course, welcome.
Thank you very much for your kind invitation. Really appreciate it. I hope you can see my presentation now.
It's okay. Yes, you can see it.
Perfect. Good. So, I'll try to be straight, brief, to the point, because you asked me to talk about management of dry eye disease. And I think when we talk management, we can't forget the DUSE-2 report, 2017, came with huge work of all these people to come to understand how we're going to manage this multifactorial disease where you got all this etiology you can see here, from the hormone influence, the autoimmunity, the environmental factors, what we cause to the eye, what we damage the homeostasis of the ocular surface, how we're going to come to a right diagnosis and how we come to right management. And this is a nice diagram where actually it looks at how you diagnose dry eye disease. And it's simple, probably all familiar with, and I'm sorry if there is a repetition here, but it tells you the patient should have a symptoms and you need one of the signs, then you have diagnosis, definition of dry eye disease. And then with some additional tests, like focusing on the tear breakup time to see if this evaporative dry eye disease, or focus on tear volume, that is tear meniscus height, to say this is more aqueous deficiency. Reality is patient fall in between evaporative and aqueous deficiency dry eye. You could be more evaporative, which is the most common case here in practice, or could be aqueous deficiency mostly or predominantly, and that's usually Sjogren disease. So we know now, we have an idea what we're dealing with and what element we're trying. And despite all long list of symptoms, long list of signs, there is always mismatch between signs and symptoms, where you got the symptoms might not match the signs. And that's why it's important to ask the patient the question. You want to know, where are we the symptom? What exactly the symptoms? And I always ask the patient to go through the OSDI questionnaire, but I also support additional questions just to narrow down my diagnosis here. I'm not going to go to the diagnosis itself because it's not the core of my talk here, but just say that you need the tools. And I'm glad to hear Dr. Jaledi talking about the inflammatory markers and how to address, because measuring osmolarity, for example, or similar, or what's going to come in the future, the key to say this is a toxic tear film that needs to be addressed. Now, so when it comes to this is another very important diagram, and put it here from the DUSE-2 report. And this is a group of patients we talked about earlier in the previous talks on this platform. We talked about those patients come to you has no symptoms, but they have some signs. Those patients coming for routine eye test, refractive surgery, for cataract operation, and then you pick up some signs. Those are the borderline on the left. You can see they're asymptomatic. There is some signs. Once you have the surgery, they become symptomatic. They turn into dry eye category. So they are preclinical dry eye disease. And we talked about symptoms that they don't match. So this is my practice, and I always go through proper assessment slit lamp, and I always go for meibography and then some treatment if required. And why I do that? Because that guides my management. We're talking about management. If you look at those meibomian glands here, I mean, these are example of patients come to you and they've been told to keep massaging the eyelids and warm compress, etc. Despite, look at bottom right, severe loss of the glands. What the patient doing at home? There's no point of expressing the glands. They don't exist. There's nothing to express. So that's why meibography play a role in guiding your management. And we know that majority of a dry eye disease actually is meibomian gland dysfunction. So it's 86%. So it's there. So you have to focus then. If you treat my MGD, you're treating 86% of your patients, which is great. And don't forget, rosacea is so much underestimated. It is very common. It is on the eyelids, lid margin, on the eyelids itself, the skin, the ocular surface. You see a lot of signs, and sometimes we miss them or we don't want to see them, but actually it does exist. And that explains to you why treatment like intense pulse light IPL does help in these cases. So when it comes to management, the DUSE report told you it's nice to go step 1, 2, 3, 4, but you don't have to, because sometimes it is so severe that actually what you want to go to jump to step 4, for example, because this is a severe disease, you don't have to go through the step 1, which is more conservative. And it throws so many tools for us. However, as I mentioned earlier, managed MGD is the key. And if that you put that in mind, then you ask yourself, what works? And I've been asked to present for Royal College of Ophthalmologists what the evidence about what works for MGD. And it was shocking, because looking through pages of literature on PubMed and going through some of the key findings, you'd be surprised that there's not enough evidence to support many of the treatment we offer to the patients. Certainly, artificial tear drops are masking symptoms. They're not really treating those patients. What works? Yes, the heating the gland and expressing them at the same time with a manual or various devices. Oral tetracycline does help. The anti-inflammatory non-steroidal immunosuppression treatment, which is Dr. Giledi just talked about, cyclosporin, tacrolimus, definitely make a difference to the management. And obviously, you've got the IPL, which is I'm going to talk about a little bit in a minute. So when it comes to the reality now, well, we are very good telling patients, I give them leaflet, I send them online to look at my website and read about omega-3 supplement, do hot mask, and massage the glands. Sometimes they don't know how to massage, so really need to follow the right technique. But only a small percentage of patients will be compliant. Patient can't do that. They don't listen to you. I don't listen. If someone told me to do that, it's really time consuming, and it's something you tend to forget easy about it. So it doesn't work so much. Only small group of patients, very good, and can follow that. The majority of patients, they need either specific treatment that you don't have to use so often, like some anti-inflammatories, cyclosporins, once, twice a day, ongoing, keep the inflammation down, keep the symptoms less. Because remember, when you reduce the inflammation, you reduce the symptoms patients talk about, even though the tear film might not improve unless you improve the function of the glands. And intense pulse light is, so these are in office where you do Plefex for treating like Demodex or lid margin disease. Intense pulse light, yes, it makes a difference to patients. And we found that IPL, and I've been doing IPL for at least since started, to be honest, since 2016, 17. We brought the first machine to London, and since then, I have not changed the way I practice dry eye disease. Not because only address the function of brain glands, bearing in mind this could be a rosacea thing, but actually the evidence showed that it reduced inflammatory markers in the tear film when you measure that. And this treatment you do in the office, but at the same time you do some manual expression for the glands at each incision. And you can see here the difference between IPL and other modalities of treatment. All other modalities of treatment, nothing give you long term, nothing specific, and it's no real impact on MGD. We've seen the glands coming back, shown up on mammography after the 4 sessions. And well, it's nice to talk about management. And before I move that, actually, I just want to go back to the tetracycline.
2 minutes to conclude, please, Dr.
That's fine. Tetracycline, please. Oral tetracycline has a good evidence, but it damaged the gut and stop patient from really using it. And we can chat about it after the talk if you have any more questions about it. So prevention is better. And that's why the new use report 2023 is about prevention. You have so many factors. I'm not going to play the video for you. This is by the TIFOS, you can see online. But what it addresses is say there are triggers to dry eye disease, to ocular surface inflammation. Sometimes we cause this, refractive surgery, Demodex causing it, or rosacea there, or our lifestyle. It's one of the 4 key elements found trigger dry eye disease. So lifestyle. So we need to look at our lifestyle, what we eat, cosmetics, food, plastic surgery we have, the Botox, fillers, all that habit. Modification of all that will have a great impact on dry eye management. So I'm not going to go through this, but there's so many coming, and I hope I'd have a chance at some stage to go through some of the key findings of the new use report about lifestyle. There's so many interesting facts. It's our duty as a specialist to pass the knowledge to our patients. Treatment conception also highlighted. It's not about just drink water. It's not about just putting artificial tear drops. It's not about if they have no symptoms, you have no dry eyes. It's a combination of various things. So in conclusion, you have to think about preclinical disease and you treat it before. So don't wait till dry eye to manifest. You might treat those patients before cataract or refractive surgery. And prevention is the key. And the management, I think, apart from heat manual expression, topical cyclosporins, topical acetylcholine, topical anti-tetracyclines, and IPL, those are the only thing in my view that works. Thank you very much.
Thank you very much, Dr. Samer Hamad. It was a very interesting presentation, and you made things difficult for me because it's very difficult to speak after all those eminent speakers. Thanks, but I will try to answer today through my last presentation to this question. Sorry, let me just share my screen. Well, here we are. Do you see my screen now? So do you hear me? Do you see my screen? Hello?
Yes, Dr. Safa, you can go ahead, please.
Okay. So does dry eye impact our surgeries and how? So my answer is obviously yes, and on many stages. Number one, on our decision making. Number two, on our measurement. Number three, on our surgical technique choice. Number four, on our IOL choice. Number five, on our results. And last but not least, on our quality of life of our patient that can make them unhappy and with worsening of symptoms. So knowing all those impacts, the ASCRS Corneal Committee built in 2019 this algorithm trying to aid surgeons to efficiently diagnose and treat visually significant ocular surface disease before any form of refractive surgery. And doesn't pass. There's a problem here. Through classifying candidates into non-visually significant ocular surface disease, which can be directly operated, and into visually significant ocular surface disease that should be assessed, treated, reevaluated before deciding whether or not they can be operated. Let's see the first impact on our decision making through this first example. Mrs. M, 27 years old, seeking for refractive surgery, stable refraction, -3 in both eyes. The topography of the left eye showed this hot spot, the high order aberration, and some irregularities in the epithelial mapping. We examine her obviously, and we see a bad tear film with irregular Myers. The ocular surface analyzer shows a bad low tear meniscus with non-invasive breakup time very low at 4 and no lipid layer at all, 0 lipid layer. So we treated her, we warned her, and we evaluated her before deciding for surgery. And if we go back to this curvature map, we can see that ectatic corneal disease and dry eye can have the same anterior curvature abnormalities. So let's be careful. Through years and through many studies, we come to the sad conclusion that cataract and refractive surgery candidates have the same frail ocular surface, because 75% are underdiagnosed and more than half of our refractive candidates have meibomian gland dysfunction. And when a traumatic event like surgery occurs on this frail surface, it automatically will lead to the dry eye. So here is our routine assessments before refractive or cataract surgery. We go slit lamp examination, visual acuity, refraction, care reading, biometry, aberrometry, and tomography. And you will be okay with me when I say that paths of cataract and refractive surgery and ocular surface disease crossroad at all those points. Let's begin by the slit lamp examination. This the ASCRS algorithm mentions before insisted on the LLPP protocol before any surgery. L like looking to the lid margin, looking for the lip cuff, which is a main symptom of dry eye, looking for the lashes, lifting the superior lid to see the limbus. P like pull the lid to evaluate laxity and see furnaces, and push to express the meibomian to see its quality. I will add the meibography to have a meibo scale, which can have an effect on our management, as said before by Dr. Samer. So let's have an idea on the impact of dry eye on our measurement, and it's the main role of the tear film. Actually, the tear film is the first and the most refractive surface. A normal tear film has no variation of refraction. At the opposite, a dry eye with irregular tear film have a variation of refraction reaching 1.3 diopter and a high order aberration that can reach more than 25%. Actually, the tear film is dynamic, and so is the vision. And this study shows the different changes in the corneal wavefront aberration at different time after the blink. And we can conclude through this study that the best time to take a capture is between the 6 and the 7 seconds after the blink, when the aberration are the lowest. Knowing all that, we can conclude that all devices based on the interior surface will have inaccurate measurement when we have a dry eye. This is what is already known, but what we learned recently is that astigmatism also changed up to 35% in dry eye population, and that pain can persist over the 6 months after surgery in the same population. Epitropoulos mentioned a very interesting notion in 2015, published in the Journal of Cataract and Refractive Surgery, showing the link between hyperosmolarity and the variability of the K reading and the measurement of astigmatism. And he concluded that in hyperosmolar group, those variation can reach up to 5 diopter astigmatism error. So objective measurement of tear osmolarity can identify patient at higher risk of refractive surprises. Now, what about the impact on the choice of our technique? So let's be fair with ourselves, and let's say that whatever the technique used, cataract corneal refractive surgery leads to a loss of corneal nerve density, but it's less pronounced with SMILE and PRK than with LASIK. What about the impact on the intraoperative or postoperative results? Apart from the debris enter the flap, the delay of healing, or those debris in the pocket of the SMILE pockets, we can face really big problem with those black islands related to the meibomian gland secretion, this pathologic meibum that can make our dissection traumatic and rough. And that can lead to corneal opacities and irregular astigmatism. Some authors can suggest to produce an active sectional loss and to interrupt surgery, treat the patient, and reevaluate him after. What about the long-term results? The impact of dry eye, it's already known. Chronic dry eye leads to regression of any treatment, any myopic LASIK treatment, which can lead us to enhancements, which enhancements can worsen this condition. Speaking about the impact on the quality of life, and here you will certainly all recognize Mrs. S that come to your office after a cataract surgery. She did what she called just a cataract with a monofocal implant. The surgery was okay, good rhexis, good refraction, while the patient reports all the symptoms of dry eye, and she insists that she had no complaints before surgery apart from decrease of vision. We examine her and we find that she had dry eye and the meibomian gland dysfunction. The ocular surface analyzer confirmed what we have seen with bad tear film, the low breakup time, and no lipid layer. The topography and the epithelial mapping shows the irregularities, and we treated her. We used all the armamentum, but despite this slight improvement, we passed from 4 in breakup time to 9 in the breakup time, and from 0 to A, she still complained, and I still see her every 2 or 3 months with the same complaints. Doctor, a nerve has been cut under my eyelid here, and I feel it. We all know the heterogeneity of cataract surgery that starts from the lid speculum and finish by the toxicity of the preservative in our drop, passing by all the steps of surgery. And this is what Typhus Gist 2 called the heterogenic dry eye. And this is what make the third of our 2020 patient unhappy after monofocal cataract surgery. And this is also the second cause of unsatisfaction after PMIOL. Well, in my part, I think that the contract was not fulfilled with Mrs. S, because to understand her suffering, we should understand what is quality of vision and supervision mean. That means not seeing more than 20/20, but for me, it means seeing 20/20 in all conditions of life. And this is definitely related to the tear film, which is one of the main actors. Let's see another feature of the impact on the quality of life, or let's say rather on life itself, because this suffering can lead to suicide, and unfortunately the examples are multiple. We still have an unmet aim, which is to identify a healthy person more susceptible to develop dry eye disease after cataract or refractive surgery. And this was the aim for Villani and its team published through this study published in 2020 in ophthalmology. They tried to build an ocular surface Friendly Index, OSFI, based on non-invasive, basic, simple data. They can be taken from the history taken or from the slit lamp examination, and they put a cutoff value of 0.3, above which some asymptomatic patients have a significantly higher risk to post-surgical dry eye. I tried it and it's really work. So my take-home messages are, they are already known, but I will insist on it. You should carefully evaluate the ocular surface before any surgery, try to optimize it, and it can take more than few days. You should predict dry eye exacerbation and provide enough explanation for postoperative dry eye, because patients are more forgiven and more accepting when they are informed. And in the near future, we can rely on the artificial intelligence that can help us in this field. I want to conclude by remembering you the Hippocratic oath that compels us to first do no harm. So don't break this ocular surface frail homeostasis. Thank you all.
Thank you very much. That's a great talk.
I thank you. So maybe we will invite Dr. Walid Zbeiba to present his talk. It was not in the schedule, but it was. They had some issues, technical issues in his session, and so maybe we can enjoy this presentation with him today.
Thank you, Dr. Yes, we had some issue yesterday with the connection, so we have the ability to let me present this talk with this session. Thank you again. So my presentation is with the IT group. So the IT can share. Yes. Okay. Bismillah ar-Rahman ar-Rahim. Hello everybody, thank you again for the invitation. My topic is about IOL fixation. I will tackle two main techniques that I have used, and while mentioning the benefits and drawbacks of each one of them. As you all know, the loss of the capsular bag is a challenging issue that could limit the ability of the surgeon to decide the type of IOL he should use. The situation could be found in aphakia situation, complicated cataract surgery, IOL exchange, or subluxated IOL. Several techniques and types of IOL are proposed to correct this condition in order to settle a stable IOL, maintaining the normal eye anatomy. Those innovation techniques will guarantee a good functional outcome and decrease complication rates. We do have three options for IOL implantation: anterior chamber IOL, iris fixation, or the non-scleral fixation. And today we're going to focus only on the commonly used option, which is the scleral fixation, since it seems closer to physiological state, because first, the IOL is near positioning to the eye nodal point. Second, it gives a minimal endothelium cells loss. And third, it decreases the rates of the ocular hypertension and outcome. The rapid rise in technology and with the great surgeon's ability, many techniques in scleral fixation have been proved, but will shed light on worldwide used Yaman technique and the recent one, Carnival technique, which I personally used. The Yaman technique was introduced in 2014 and modified in 2017 with the different varieties. We use three pieces intraocular lens. The one with polyvinylidene or PVDF haptics gives the finest stability in the sclera. This kind of IOL called Lucia Zeiss IOL. Now let's take a look to a video of this technique. As you see, we don't need expensive instruments to do it. After the injection of the IOL in the anterior chamber, 27 gauge thin wall needles are passed transconjunctively, 2 mm posterior to the lambus and 180 degrees apart. Tunneled through scleral and past intravitreous cavity, the haptics are docked into these needles, which are simultaneously withdrawn. Externalized haptic ends are met with cautery, creating bulb-shaped phalange, which are pushed back under the conjunctiva and then into the scleral tunnel. According to my experience, introducing the IOL via a scleral incision facilitates the maneuvering of both haptics and needles. Disadvantages are various, like the absence of the medical contraindication, codified surgical techniques with standard IOL, no complication related to the suture and the glue, minimal ovular contacts. Let's move on the Carloval IOL, which is the last test method for the correction of lost capsular bag. It's the first implant dedicated to the scleral fixation, foldable one and acrylic. It passed through 2.2 mm incision. It has a special design that gives a high stability and centration. Its fixation was assured by anchoring in the sclera of two T-shaped haptic. Passed through 20 gauge or 23 gauge sclerotomy, placed in the sclera flap. Also, it has a special body that reduces the risk of iris capture and papillary block, with total diameter more than 13 millimeters and 10 degrees angulation for the haptics. Let's move to the Carver IOL implantation. After conjugal dissection, we make a corvitrectomy, capsular remain removal. We make two radial grooves, scleral grooves. After that, we make scleral pocket in each side with the crescent knives. And we introduce 25 needles at 2 millimeters of the lambus. We loaded the IOL in the midi-cell injector, and then we introduce the IOL through 2.2 millimeters corneal incision. After that, we grasp the anchor of the IOL by two on the ocular forceps, and we externalized and we placed this, the anchor into the scleral pocket. And we placed the plug in the pocket, scleral pocket, and then we sutured the sclera and the conjunctiva. Another case of IOL implantation, Carloval. In this case, we use transscleral trocar 25, and then we extend the plugs and we put them in the scleral pocket. And finally, we sutured the sclera and the conjunctiva with 7-0 Vicryl. A lot of advantage, no contradiction, no suture or no glue required, an excellent centration of the IOL without tilt, no ovular contact, and the situation of the iris into the eye is independent of the iris change. With this technique, we have an impressive result. Like you see on this photo, first day post-operative, clear cornea, well-centrated IOL without tilt. With the UBM investigation, we can objective there is no contact with the oval structure, and we can find out the anchors into the scleral layers. With this type of IOL, we have more than 70% of visual acuity improvement. For this, we use Haferku, Holiday, or SRKT formula to calculate the power of the lenses. According to several studies, Carnival IOL demonstrated a superiority in terms of refractive outcome and induced astigmatism compared to Iris Claw and Yaman technique with MA60 IOL of Alcon manufacture, with low risk of decentration and iris capture. And finally, it's a promising solution in the loss of capsular bag with a few complications, well adapted designed, but long-term results are needed.
Thank you very much. Thank you very much. It was a great presentation. Technique that seems promising. I don't know how long is your follow-up after your first Caravali implants.
So I did several cases and compared a lot of patient between Yaman technique and Carnival. And high follow-up, I have two years now. I did this, yes, and it's stable.
Everything okay?
Yes, without problem, because especially without decentration and without tilt of the IOL in the eye. It's the main problem with Yaman technique, and
the learning curve seems shorter than Yamani. The learning curve of
so the problem, no, it's not a problem, but I think the issue with this kind of implantation, we have to do a core vitrectomy before implantation. This why we have when we maneuvering this the implant into the eye, we tilt into the anterior vitreous, and we have a lot of risk to create some retina tears. So we have to do vitrectomy before implantation. That's why the time of the surgery is more longer.
That's it. Thank you very much, Dr. Walid.
Okay.
You are welcome.
Thank you.
So
Thank you.
I
Thank you.
just one question for Dr. Samer Hamada, if he's still with us. Dr. Samer?
Yes, I'm with you.
Yeah, I just want to give us your inputs about the tetracycline. You mentioned it while we were talking, and it seems very interesting to be known. Please, it's yours.
Yeah, sure. So unfortunately, since the evidence about the help of tetracyclines, and that's usually either doxycycline, I'm talking about the practice in the UK, West Europe, tetracyclines, doxycycline, like 100 milligram, give it for 3 months and can repeat it, or azithromycin, which we give it like 5 days a month and then repeat every month. However, there is more evidence now that affect the microbiome of the gut. And if anything, actually, you might cause more inflammatory changes. Plus, obviously, those patients can have other symptoms not to do with the tetracycline. And personally, I used to use it heavily, like almost most of the patients. Now it's limited to use it for those with obvious bad rosacea, and I give them a severe warning. We had a patient who got benign intracranial hypertension after doxycycline. I've seen all the varieties. I've seen the patient who went for functional medicine, and she had a candida infestation, had gut, and tetracycline actually did not help. So there's a lot of things we have really to think before we give the patient tetracycline, and usually the patient will resist. Those who read a lot about it,
safe as we think. It's not as safe as we think. So we should think before.
Exactly.
Thank you. Dr. Usama, I don't see Dr. Safwan. Maybe he left. I just want to ask you about your what is your experience with the Xidra now, 2 years after the launching of the product in the Emirates? And second question, how long you keep the anti-inflammatory treatment in your patients tell you, and you tell yourself, okay, it's enough, I can stop now and keep it just under artificial tears?
Thank you very much. Lafitograph Zidra, we're using it more than 2 years. Yeah, it's effective, same like cyclosporine almost, but the start effect is faster. 2 weeks to 3 weeks, people feel effect. Although the stinging same, maybe some people report maybe slightly stinging a little bit more than Restasis, but it's effective. Regarding the duration, really, I always I use it for long periods. So minimum 6 months. And then, but some people, the patients 2-3 years, some of them. So it depends how much the level of dryness and how much is the symptom and how much lubricant still he needs. So there's
And
no time frame.
You don't go
Yeah.
for taparine? You don't go for taparine, you stop it right? No.
Just twice a day anyway. We use weaker steroid, weaker cyclosporine is twice a day, for example, or Zitra. So twice a day, there's no point to tapering either to control or not. So twice a day is, I think if the dry is much better, inflammation is much better, and patient using the surface look very good, I just ask him to use just lubricant only, and we stop it. Well, we are lucky really here also, the insurance cover most of our patients, so that's another bonus.
Thank you very much. Thank you very much, Dr. Usama. And I think that we have we will close this session. I will thank all our guests or our speakers, and I will remember and make you kindly remind to our Mayom meeting in October in Dubai. Inshallah, we'll meet there and we'll enjoy science and friends. Thank you very much.
Thank you very much, everyone. Good night.
Yeah, right.